Thank you, Salima, for showing us how to incorporate healthy foods into our diet. We'll now head into the topic of survivorship with Dr. Jennifer Klemp. Dr. Klemp is a professor of medicine in the Division of Medical Oncology, the director of cancer survivorship, and the co-program leader for cancer prevention and control at the University of Kansas Cancer Center. Her clinical research practice focuses on cancer genetics and cancer survivorship. Dr. Klemp serves on a number of national boards, is an expert in cancer genetics and survivorship, and has presented her work nationally, focusing on cancer genetics, shared decision-making regarding options to manage cancer risk and survivorship issues, and the development and implementation of cancer genetics, survivorship, and navigation programming.
Hello, and thank you for the opportunity to discuss current issues related to cancer survivorship. I want to start with kind of right-sizing what we mean by cancer survivorship and some of the guidelines that have really framed how we think about cancer survivorship, how we deliver survivorship care, and really some of the key issues related to cancer survivors. So in the most recent updates for the National Conference of Cancer Network guidelines addressing survivorship, and this was published earlier this year, it's anyone who is diagnosed with cancer for the balance of his or her life. And it also includes this more comprehensive definition of family members, friends, and caregivers, because that whole sort of unit that supports an individual with cancer is really part of that survivorship experience. And so I think the important part about from the diagnosis through lifespan really means that it's not just during treatment that we think about the issues related to survivorship. It needs to begin at the time of diagnosis and really be throughout the lifespan. I think it also really needs to focus on these potential issues related to not only physical health, but psychosocial health, and not only kind of how one views self, but sexual health. And one of the more current issues that's really received a lot of attention, especially during and post-COVID, is financial toxicity. So this can look a little different, right? So you may have patients who live cancer-free for the remainder of their life. You may have patients who live cancer-free, but also could experience one or more late effects, kind of serious side effects that may have either been accelerated by the diagnosis and treatment, or also, unfortunately, our patients have quite a few pre-existing or comorbid conditions, and cancer along with its treatment can kind of additively cause an increased risk for many of our patients. We also know that sometimes patients will live cancer-free and develop a recurrence. Maybe they'll develop a second cancer. Some of our patients will never be free of their cancer, and they will live with cancer, constantly getting new treatments and being exposed to clinical trials. So this is the face of cancer survivorship, and it looks different for each individual, and people are going to kind of ebb and flow depending on where they are in their cancer journey. And this really is sort of highlighted by what's called the silver tsunami. And this is the growing population of cancer survivors. And it's called the silver tsunami because 2/3 of cancer patients are 65 or older, but we do have 1/3 of our patients who are under 65. So this population in the green, purple, and blue bars really does signify patients who most likely have 3 or 4 other comorbid conditions. We also know that cancer is a disease of aging. So obviously one risk factor that we can't really do a whole lot about is the fact that we do get older. And that's one of those common risk factors that we all have. We also know that the experience of someone who's 35 may look a little bit different than someone who's 65 or 75, not only because of the life experiences that they've been able to undergo, but also where they are in the lifespan, where they are in regards to menopause, where they are in regards to, these other comorbid conditions. So age does play a difference. We do need to think about this growing population, as you can see here, a significant number from 2016 on up to 2040, we're going to see, more than a doubling almost of cancer survivors. And those are patients, once again, living with or through their disease. So when we think about survivorship and putting this into action, that's where we really want to begin at the time of diagnosis. We need to think about how we navigate and how a journey can look. Not only does that include a treatment plan, but it includes genetics, sexual health, cardiotoxicity, radiation. These are just a few of the examples that need to be thought about as an individual embarks on their cancer journey. And then how do we use palliative care or symptom management and really supporting our cancer survivors, support services and other specialists like cardiologists and endocrinologists. And then what about our primary care physicians? How do they fit into this paradigm? So as you can see by this figure, there's little roundabouts, and it's just like it looks. Sometimes a patient goes through a treatment phase, the roundabout will take them into the next phase, or maybe they'll continue to kind of go back and stay in that treatment phase of care. Other patients will go on and have a recurrence later and then come back into a treatment phase. And other patients will go into continuity of care, or this is kind of considered that long-term survivorship. We still need a lot of those aspects of navigation, of survivorship care planning. Think about our heart, our brain, our bones. We need to exercise and keep moving and think about lifestyle. And we also need to think about how a lot of these other factors that may have played a role earlier in the diagnosis may also still be important into longer term survivorship. So as you can see, survivorship is a continuum. It is a journey that a patient will embark upon, but there's not lots of sort of these roundabouts or sort of mergers that will happen. And we need to be prepared and not only empower the survivor to be part of this process, but how do we provide the types of services, the types of education and assessment that are needed. So that means we need to risk stratify. And this is a term which we think about in lots of different ways, but how do we identify what's the biggest risk for the individual sitting in front of us? Is it the single or multimodality, meaning multiple treatments that a patient underwent, a survivor was exposed to? Or is it those baseline comorbid conditions like cardiovascular disease or diabetes or hypertension? Or is it things that may happen to an individual as a course of their treatment, like fatigue, loss of fertility, changes in sexual health and menopause status. So these are important factors to think about because they're going to impact not only when you may see the onset, such as something long-term could happen both during a diagnosis and persist. So oftentimes we think about things like fatigue, fertility. Those are things that could be impacted both during treatment, but have a long-term effect even into post-treatment. Versus late effects, which maybe are going to happen down the road. And oftentimes we're thinking about bone loss or cardiotoxicity. So we really need to have sort of the thought process of what do we need to think about today? How does it impact us in the short and long term? And then how do we help identify the greatest risk for the survivor? And what do we do about it? How do we educate? How do we hopefully disrupt that risk? Or at least identify early and manage that. So when we think about the greatest risk, we know that, for instance, early stage breast cancer survivors who are over 65 have an equal to or greater chance of dying of cardiovascular disease than their cancer. So are we doing a good job preparing our patients for what that's going to look like based on the treatments that we gave and really empowering them with a plan to help sort of mitigate or disrupt that risk? So this is a figure I wanted to show you that really kind of helps put into context some of these late and long-term effects. As you can see, it really is sort of head to toe when we think about cognitive or sort of how our brain and some of the impacts of not only cancer diagnosis, but treatment, and then the natural process of aging. And what about some of our neurologic? So sometimes people think about neuropathy or some of those types of issues. What about our heart? What type of damage has occurred and how does that play into some of the comorbid conditions, maybe hypertension, family history of cardiovascular disease? And then we give a treatment that we know can damage the heart. And then what about our bones? And what about sexual health? And then, of course, psychosocial functioning. So this sort of bigger picture really does help put into context that this is a kind of a head-to-toe sort of assessment that we need to do, not only to educate the survivor on what the potential late effects could be, but also how do we start sort of assessing, educating, and when do we reassess? How do we intervene? How do we disrupt some of these potential late and long-term effects? So this process that's outlined here is a stepwise process based on the greatest risk, but it also is important to think about, we can't just assess one time. Maybe we need to assess along the journey, and we need to constantly be thinking about how a patient's health status, a patient where they are in the lifespan, and some of these other kind of competing issues, how do all these things play together in order for us to help manage some of the late and long-term effects of cancer and the treatment of cancer. So this is a new term that's sort of been thrown out because this is complicating the picture, and it's called multiple chronic conditions. And this is not as uncommon as it used to be. We know that our average breast cancer survivor in particular has over three chronic conditions. So they would fall into this multiple chronic condition category. And the most common ones that we see are hypertension, which is obviously high blood pressure, the irregular lipids, diabetes, chronic kidney disease, AFib, also something affecting the heart. So when you start putting all these pieces together, who's responsible, right? We have the cancer care team, we have our primary care, we have specialists, and then what about our caregivers and ourselves? So this complex picture, especially as an individual goes through that cancer journey, we think about sometimes we get siloed, right? So cancer is really intense. We get siloed in a cancer center, and are we really engaging some of those other specialists or our primary care in managing some of those comorbid conditions? So it really does mean that we need to figure out how to communicate better, how to have that crosstalk, and how to role delineate so we can get the best possible care as a survivor or in helping to care for our survivors. So that means we need to have sort of a village around us, a circle of care. It doesn't mean every patient needs all of these different services, but it means we need to have individuals that if we send a patient to the cardiologist, they're not saying, oh, well, we'll see you back in 6 months. Maybe a patient's on treatment, they have a change in a cardiac marker, and we want that cardiologist to really be thinking about, okay, the job here today is to keep this patient on treatment. So we need to sort of have a short-term plan, not I'll do my normal and see you back in 6 months. So these are the types of relationships that are really important when we think about building this circle of care, is that this team and this wide net really does need to have a level of expertise and comfort in managing cancer survivors. And so putting this risk stratification into a little bit more of a deeper dive means that we have to kind of break individuals up into buckets. So to the low risk, the moderate risk, and the high risk. And when you think about these different buckets, that means we have to have some needs assessments. We have to be thinking about how these comorbid conditions play into that. And then what are the tools we need to have in our toolbox to manage patients in these different buckets? If they're at low risk, at moderate risk, or at high risk, how do we navigate them? What are the other shared care partners we need to have on board? And how do we engage and educate the patient along with the use of technology? So this shows you that we need to be assessing at different time points, both at baseline, before and after primary treatment, into long-term follow-up care. And we need to have some set time points where we assess a patient, both maybe with self-report from the survivor themselves, or something that we would do more as part of a visit and sort of that interview process. We also need to think about how in the low, moderate, and high risk buckets, what types of treatments were given, what types of comorbid conditions exist. So putting patients into buckets isn't meant to isolate them in this box. It's really meant to help guide us as to what types of resources and education and interventions would be most appropriate based on what has happened to the survivor and what options we have available to help hopefully address those issues. So what can a survivor do? Well, first off, we need survivor engagement. We need to make sure cancer survivors are showing up at their appointments, they're getting their cancer screenings, they're adherent to their long-term medications that they may be on for 5 to 10 years. We may need to do update or initial genetic testing, lifestyle modification, smoking cessation. These are all important parts of a survivor's role in really being part of their follow-up and survivorship care. We know that lifestyle is huge, not only for cancer prevention and survivorship, but diabetes and heart disease. So it really does go along with sort of that whole picture. And we know we want to be as lean as possible. We want to eat a healthy diet. We want to limit our alcohol consumption. We also want to keep moving and avoid inactivity, whether it's chair-based exercises or other types of movement, walking, classes, you name it. Depending on the level of a patient's abilities, we want to make sure that they don't stop moving. And we know that a mix of both cardiovascular and strength training is really probably our best bet, and that's been outlined by the American College of Sports Medicine. We also know that cancer survivors are not always getting their mammograms. So these blue bars show how many survivors are getting their mammogram. So at 10 years out, we're down to about 60% of breast cancer survivors getting their breast cancer screening or their mammograms. So why is that? So this demonstrates that survivors have to be part of that process. And if your provider doesn't say, hey, here's your order for your mammogram, let's go ahead and make sure we're asking that question. Or maybe they think the primary is going to be doing that now, or you haven't seen the oncologist. So we need to make sure that that is a non-negotiable. That needs to happen. And we need to make sure that survivors understand that just because they're 10 years out, like in this slide, doesn't mean that they still shouldn't be getting that mammogram. So this needs to be way up here, and we need to change the colors of these bars. And this is a large Medicare database, which means it's patients who are over 65. So really important to put this into context. And we need to make sure we have a plan. This is an example of some of the recommendations off of our cancer survivorship plan. And we actually role delineate. So not only do the different physicians know who's doing what, but also the patient knows or the survivor knows who's going to be responsible for ordering the mammogram or the bone density or coordination of care. So this is another level of survivorship that I think is really important, but has definitely become sort of highlighted as an issue, because sometimes each of your providers have the best intentions, but they may be assuming that the other provider is going to do the ordering of a mammogram. So we have to have role delineation. So that means there needs to be coordination between primary care and oncology. We need to not only role delineate, but we need to share who is responsible for what those risks are. And so I think that this level of communication really is coming to the forefront as imperative. In order for survivors to get the best possible care, we have to have coordination of care. And some of these themes like communication, knowledge, access to resources, and just the organizational structure of what's available really do play into that picture. And then lastly, I did want to touch base on financial toxicity. And it used to be that the initial phase of care was the most expensive. But now, because patients are living so much longer with and through their diagnosis, the continuing phase of care or survivorship phase has become really the most expensive time. And this shows you previous kind of 2010 dollars versus 2020 dollars. So the important part of this is that it means that we need to circle back to financial counselors. We need to understand what can be covered by our insurance and at what intervals. We need to use state-based programs, especially there are many programs, especially funded through the Centers for Disease Control or CDC, which allow for different financial brackets to get access to low cost or free mammography and other types of imaging. And I think during COVID, where we've seen so much transition in insurance and patients' level of reimbursement, or loss of insurance, we really need to be familiar with how do we help our survivors access these programs so that we can make sure that they stay consistent with guidelines and stay up on their survivorship follow-up. But I think this is really important for us to talk about because it's uncomfortable to talk about. But if we talk about it with every patient, then we normalize the discussion around finances. And that's a really important thing to do, not just in general, but especially because this past year has really taken a toll on so many individuals, their families, and our healthcare system. So financial toxicity should be part of that standard dialogue, and the use of financial counselors is really important in addressing some of these ongoing financial toxicities. So I hate to end on such a topic like financial toxicity, but I think it really does reinforce that when we think about cancer survivorship, whether we're talking about late and long-term effects, not only from the physical or psychosocial standpoint, we know that financial toxicity, we know that understanding all of these comprehensive needs of our cancer survivors is imperative in order for us to really help patients not only in the acute or the phase during treatment, but as a patient gets farther out from their diagnosis. So I hope today we did a rapid review of sort of the common and hot aspects of cancer survivorship, and I want to thank you all for your time.